Suicide Fatality Review Manual was made a little bit easier because Ohio already had the overdose fatality review manual. So the work group took the overdose fatality review manual and then some guidance from the National Center for Fatality Review and Prevention. They had a program manual. So we used that and then created this manual that is a living document in that it's meant to be changed and updated. But after many meetings and edits, it was finally ready and it was released in the fall of 2024, either the day of or the day before we had our first Ohio Suicide Fatality Review Best Practice Summit, which was hosted by OSPF. And so, again, that is meant to be a living document. What you are going to see in 2026 is that work group, or at least a small portion of the work group, will be joining and meeting again because there's some edits that need to be made. We've listened to some of our partners who've given us some feedback saying, hey, we'd like to see some templates on this in the manual, or there's just some edits that we have to make along the way. As you know, when you guys create things, edits need to be made. But we are going to be working on updating that manual. If you've not ever seen that manual, and I hope if you're on this call you have, but you can, if you just Google the Ohio Suicide Fatality Review Manual, it comes up. Next slide, please. If you're just thinking about setting up a committee and you've not looked at the manual before, on your screen is basically everything that's in the manual. It walks you through how do you establish a committee. It talks about how do you develop the confidentiality and information security protocols. How do you develop meeting protocols? How do you conduct the case reviews? Recommending and developing plans. And then how do you complete the annual report? Again, there's some stuff on evaluation and then tools for best practice. But the one that we're seeing, the stuff we're seeing used the most are those templates in the back of the manual, which you're not required to use, even if you have an SFR. They're just suggestions. But I can tell from the Suicide Fatality Review annual reports that I'm getting in that many of you guys are utilizing those templates and you've provided feedback on them, which has been greatly appreciated. So thank you. Next slide, please. Okay, we're going to go over everybody's fun stuff, which is the Ohio Revised Code. I'm not going to go over all the Ohio Revised Code because there's several Ohio Revised Codes that deal with SFRs, but I want to go over a couple brief things. So in the Ohio Revised Code 307.643, it basically describes the purpose of the SFR, which is to decrease the incidence of preventable suicide deaths. And in Ohio, we believe this can be done through those key bullets up there, promoting and collaborating, maintaining a comprehensive database, recommending and developing plans, and advising the health department, so your local health departments and in the state on aggravated data trends and patterns. Okay, so that's the purpose behind that, is to decrease and eliminate suicides, but through this process. Next slide, please. Okay. There are specific Ohio Revised Codes related to SFR. I listed a couple of them up here, especially when you're starting to set it up. Like there are specific expectations of confidentiality of your committee. We did want to point out a couple things that are in there, that there are sections that SFRs are not required to be public meetings, so they're not subject to public information requests. A lot of people have questions about that. And then there's sections that focus on immunity, which is important for both partners and people on the committee, that you do have immunity when you're sharing for your committee and stuff like that. Next slide, please. So there's a couple other things I wanted to point out. When you're looking at the Code of Federal Regulations related to HIPAA, because this has been a common question that we have asked about that, according to this one here, we have checked with the legal several times, but medical information can be released to the Committee for Public Health Authorities and Regulations to advise the SFR committees. We know we've had some issues with that on some communities and different agencies in the communities not wanting to release it, but in the Code of Federal Regulations, it does fall under them being able to release this information because the information was released is then, confidential and everything. The ORC does have clear guidance on how do you establish the SFR, who needs to be there. If you do a hybrid committee, who should be leading the hybrid committee based on everything. And if you do a regional, because you are allowed to do a regional approach under the Higher Revised Code, if you do a regional, who should lead that? Who has to be sitting at the table? And then who should be the chairperson? Okay, I wanted to just list that in case you wanted to look at that. Next slide, please. So the next one, you see an Ohio Administrative Code. So if you're not familiar with the difference, the Ohio Revised Code is the legislation, where the Ohio Administrative Code is kind of like providing more guidance on what is in the Ohio Revised Code. So right now, ODH has worked on submitting rules, which is what's called the Ohio Administrative Code, related to the Suicide Fatality Review. If you Google that number and up the top, it's probably not going to show anything because the rules haven't been published yet. They were open for public review. We didn't get any comments. We got a couple questions, but no comments. And so it's just going through the rule process. But when those come out, it will have, more information about compiling case data, creating and maintaining your comprehensive data, and reporting on that, and uniform record keeping. There's a little bit more in the Ohio Administrative Code related to the OFR than the SFR. So keep that in mind when you see them. They are combined, but there's a little bit more for the overdose. So if you happen to do overdose as well, just pay attention to that when they do come out. Next slide, please. Okay. So one thing that I am tasked with at the Ohio Department of Health is making sure that you guys, whoever has a suicide fatality review committee, is giving guidance on how to submit your annual report and what is supposed to be completed in that report. So if you've never done an annual report, they're due by April 1st. So in 2026, April 1st, 2026, your annual report for 2025 will be due. Okay, so what will happen is on our ODH's website, we do have guidance out there for the submission of your report. What will happen is we provide you the metrics that has to be included, and it's already listed in the Ohio Revised Code, but it's in a guidance document for you. And then we provide a link for you to enter your information and a section for you to upload your narrative. Okay, so what is happening right now is we received some feedback from some local health departments about, hey, sometimes this was a little confusing. We weren't sure what to submit. So we are updating the guidance now to make it clearer. And so that should be done in the next few weeks. And then what will happen is we'll update our website. We will also go on the weekly local health department calls and let people know when we have published it. And I will be sending out an email to all the agencies that we know, the local health departments, that have a suicide fatality review committee. Okay, we're just going to do that one as a courteous, just to say, hey, here's the link, and everything like that. So you have plenty of notice about when that is. But my section is the one where the reports get to, and so if you have any questions, you can reach out to me directly as well. Next slide, please. And the wrong slide. Let's see here. One more slide. There you go. So I wanted to give you a little bit of recap of what we're seeing at the Ohio Department of Health. And most of this, we haven't looked at all the 2024 data, but I wanted to let you know. So what we received in 2025 was obviously for 2024, and you can keep going back. So when we first were starting to get data, we received 10 reports that first year. Well, we had 10 surveys completed because the Red Cat link has some questions, and then you're supposed to upload a report. We had 10 surveys reported, but only 8 actually submitted narratives. And you can see every year we're getting a little better. This last year we had 30 surveys reported, but only 29 reports uploaded. And a couple of them we actually were not able to keep because the local health department, because that's just who submits it, they actually submitted personal identifiable information of the cases reviewed, and we had to destroy that. And so we have reached out to those agencies and let them know that. But you can see we're increasing every year. The more that this is getting out, more that is getting established, more technical assistance that's being offered, we're getting more and more. There's some other data that we're going to go on here. There's a lot of meetings. The 2024 obviously had a lot more meetings than in 2023. There was 23 meetings. I think in the 2024, when I was counting it, we were up to like 100 meetings. I didn't update the slide, but it's definitely increasing as more and more. Next slide, please. This is just another data thing of how many partners we had involved in suicide fatality reviews among the different ones. So you can see we're just continuing to increase. Next slide, please. So in 2022, after the legislation, we got our first batch of reports. We received 10 full reports, and you can see that that's there on the left. The map on the right is actually a map that is on, it's a live map that's on Ohio Suicide Prevention Foundation's website, and I pulled it on Monday, and it shows that we have 44 counties now that have suicide fatality review committees in some way. Some of them may be way at the beginning, some of them may be fully active, some of them might be paused for a little bit. Dallas and I agree that this map is not, we're missing some people. So if you look on there and you're like, oh man, my county's not listed, put it in the chat so we can get that updated. We know that there are more, but it really shows a good picture of Ohio. We've got over half of the counties that now have SFRs on this important work. So whatever you guys are doing, just keep up the great work. But if you're not, you're looking at that map on the right, you're like, oh, we have one, or we're in talks, then let us know like you guys are doing. So thank you for letting us know, because OSPF does want to get the website updated, so we appreciate that. Next slide, too. So I wanted to go over a couple things that we're seeing in the SFRs right now. So full disclosure, I am not an epi and I'm not an evaluator. We're working on that. So I'm going to go over some things that we are seeing that the epis helped us look at a little bit with our SFRs, the reports that are coming in. So you can see on this one, this is just the deaths review by age group. This is not all the suicides that occurred. This is just the cases that were reviewed. So in 2022, you can see that clearly that middle age group, 35 to 44, had more reviews. And then in the 2023, it started spreading out just a little bit more equally. And we imagine that that will change as trends in the suicide are changing as well. Next slide. So this next slide is the percent of suicide deaths reviewed by age group. And this is for the 2023. Okay, so you can see that the most notable is more of the older adults are getting reviewed. And I think for some counties, that's intentional because you guys are seeing an increase in among older adults, which the Ohio Department of Health is paying attention to. We're trying to include that in our state health improvement plan as a priority population, the older adults, which we've never done before. So we are using the metrics and the information that you're giving us. So I just wanted to point that out. Next slide, please. So this is for 2022, the percent of suicide deaths reviewed by demographic groups, which I don't think that this surprises that many based on the data that the highest groups are males and usually white non-Hispanics, but that's how it's been broken out. Again, this is not the suicides that occurred. This is just the suicides that were reviewed. Next slide. And this is just a different breakdown for 2023. Not much difference between 22 and 23. So if you look at the next slide, please. So what we did is we took the trends. So in the annual reports, a lot of things that the last section of the annual report is recommendations or trends or patterns at the local level you guys are seeing. So we just created a word cloud of terms and trends and patterns that we were seeing the most often. And obviously you could see the gunshot, firearms, white, non-Hispanic, history of law enforcement, history of suicide attempts. In 2022 came to the forefront. And if we look at the next slide, not much has really changed on that, right? It's very similar what's going on. Um, and so next slide here. I didn't do the 2024. When I looked at the 2024, it was very similar to 2023. So at ODH, our next steps are one, I'm updating the guidance for the 2024 annual report. If any of you guys have suggestions on that, feel free. I'm going to put my information in the chat. Feel free to message me. I have met with a couple local health departments already, and they gave me some feedback, and I greatly appreciate it. But you can send me your suggestions and why you feel this way. And if we need to meet, we can meet. It's not a problem. We will work on updating the SFR manual with a little bit more templates and just some updated information. At ODH, we are working on getting a contract out there for an evaluator because it's a little bit different than the child fatality reviews. The Ohio Revised Code doesn't actually say that ODH has to do an annual report, but we know we want to do one. We think it's useful. So we have a contract that is being written right now so that we can work more on doing the evaluation. I think if we get this year in, we're going to have 4 good years of reports, and that's some good data to try to create a report on. We're going to continue working with OSPF on giving technical assistance to any of the SFRs or counties that are wanting to set up one or they want to enhance it. And I did want to bring this up that we have created a checklist on best practices for bylaws. And we've had some local health departments that have sent their bylaws to us, and we've looked over them and we've given them some feedback on it, which people have felt it's useful. We've had a couple, and I owe somebody some information, and she's on the call, so she's gonna know what I'm talking about, that have reached out for an examples of some things that other communities have done, so we can make those connections with you if you need connections to other SFRs out there that maybe they're doing a hybrid approach and you want to move to that. Maybe they have a hybrid approach, but they're going to separate them out. How will that look? So reach out to us. You can reach out to OSPF and everything like that. I did want to talk about how we use the SFR results. So right now, how we're using them is a lot of times we're using it to justify and seek out other funding for some projects. For example, even though we had it in our grant application with CDC, we could have changed our adult male population. We had the opportunity to change what population we were going to pursue with some of the funding. We knew we wanted to stay with youth, but looking at the data, all of the reports that we were getting had a clear indication that the adult male group was a high priority for Ohio's and the SFRs. So we've taken that, and that's why we entered into the partnership with Ohio Suicide Prevention Foundation. So they're going to be leading a work group for the adult male populations ages 25 to 59. And why we have 10 high burden counties that we've reached out to Ohio Department of Health has reached out to them. We did some question and answer sessions. In fact, we still have one tomorrow. Letting those 10 high risk, high burden counties talk to us and ask us questions. So OSPF will be forming this work group. They're going to be working on specific suicide prevention activities within statewide, but also those counties. So any community can join this collaboration. They're just going to make sure that those 10 counties, if they want to be involved, are also involved. But part of that is OSPF also, which I think it's going to be Dallas, giving the technical assistance like he's been doing. I know him, he's done it. Austin has done it through OSPF. Several people have been going around and really working on that. So that's going to continue to do. One thing we were able to do, just based on the mechanism of suicide, right? The firearms. You guys are all seeing that in your communities. So, the nature of the state that we live in, it's very hard to talk about firearms, period, especially from a state perspective. But I was able to use the annual reports and the information in the annual reports. Not only that, but with the passage of the marijuana law and everything, because remember, drug overdose and all, and harm reduction also sits in my area at ODH, even though I don't deal with it. So we were able to use that information from the SFR reports, just the overall state data, and the fact of the marijuana law. And I'm also in child injury, so I deal with the cannabis poisoning and all the costs of poison control, right? So we were able to use that, and we are partnering with Ohio AAP, and we're doing a lethal means project. And basically what that is why they are providing education in lockboxes to pediatric and family providers, and why it's meant for people that see pediatric patients. Assumably, those pediatric patients have adults in the house, right? And so the adults are who has been giving the information on reducing access to lethal means in the house, which includes firearms, it includes drugs, it includes household products. So they're given lock boxes and not necessarily the gun locks. We went that route specifically so that different types of lethality could be addressed. But your SFR reports did help with that. It was the leverage we needed to be able to look. This is what's being recommended. And so we are now getting ready to do the third wave of distribution of the lock boxes. So if that's something that you're interested in, it's through Ohio AAP. It's their Store It Safe program. So Store It Safe is just a lethal means project in education. Many of you guys have been involved with that, but it's not specific just to pediatrics. Yes, they give the lock boxes in education to pediatric providers, but again, they're also doing family providers. So if that's something you're interested in, I can make those connections with you on that. I think that was my last slide, Dallas. I'm going to put my information in the chat. I don't know if there's any questions in the chat. If anybody has, feel free to ask me. I wasn't looking at the chat, so I apologize.
Yes, hi. I'm from Lake and Geauga counties. I was just wondering, will there be a national data entry system ever implemented like we have for CFR?
Yeah, I don't have an answer to that. We've asked, and CDC just isn't saying right now at this point. Um, I don't know because the CFRs are a little bit different because they are mandated, and the SFRs are not. At this point, we've asked the question, and CDC has just said they don't have any information on that at this time. I will say, with all the different things that have gone on with CDC, suicide prevention still seems to be at the forefront for them, which very grateful for, right? I think we all are. So it wouldn't surprise me. I think they're just behind the eight ball compared to like the CFRs. But it wouldn't surprise me if it happens. I just don't think it's being discussed right now. But I would say that in your SFR annual reports, it's not a bad idea to put that recommendation in there because I can use that as leverage too when I'm reporting up to CDC because we meet with CDC every month on the suicide stuff.
Okay, great. Thank you.
Thank you. Well, I put my information in the chat. So if any of you have any questions, you have recommendations for the SFR annual report, just anything, just reach out to me. And Megan, yep, you're the one I owe information to. So um, this is an example. Megan reached out to me and asked how many were doing hybrid SFRs and OFRs, right? And so I'm going to give her some information on that and try to, connect some people with her. Um, yes, thank you, Megan. Oh, I'm trying to look at the other question in there. So the Ohio Revised Code, I'm looking at the questions. Are there qualifications required for the individuals that conduct next of kin interviews? The Ohio Revised Code does not have any qualifications listed. I don't know if Dallas, you want to talk about the next of kin interviews and how all that works.
Yeah, I can definitely talk a little bit about it. I know that's something that we are looking to continue to train on. And so I'll talk about that a little bit here in a second. Just kind of want to go ahead and try to move it forward as quickly as possible to get into our guest speakers. But yes, like retrospective fatality analysis, which helps with next of kin interviews, deep dive, understanding the psychosocial factors leading to someone contemplating suicide and then unfortunately going through with it. Is definitely a focus because we want to be able to bring out that information as it's extremely vital and important to inform the fatality review that information because it's going to give us a better understanding as to what some of those leading factors are so that we can then kind of take those factors head on and try to prevent those future suicides from happening again. So yeah, I'll cover it a little bit here in a second, but definitely always something that I can connect with you in the future and we can kind of dive a little bit deeper into that and try to see if that training is something that you would like to provide to some individuals in your community. But I will go ahead and just go ahead and move us forward for now. Alrighty, and I will definitely, I'll move through this a little bit quick just for time's sake, but just started with a couple of figures. These are figures that I find to be really important because and they just kind of give us an understanding of the groups and individuals that we're working with within this postvention space. So historically, they talked about how there was about 6 people that were affected by each individual suicide, which with some extra actually look into that, some surveys and some evidence, that number is actually around 135. For every suicide that occurs, you have people that are exposed, affected, short-term bereaved, as well as long-term bereaved. And just another figure to kind of give you a better look at that. These are just some of those groups and individuals that fall within those spaces. This is not all inclusive. Clearly, there's more people that would fall in these sections. And just because they're listed in one doesn't mean they cannot be listed in the other. But this is kind of gives you an idea that postvention isn't really just always about the individual that is bereaved. It also affects communities, certain agencies, schools, workplaces. And so it's really important as we're going through the fatality review to look at recommendations that will impact all of these different levels of exposure up to the long-term bereavement. This is just a circular model of suicide reduction. I'm sure many of you have seen how prevention is depicted as an arch where prevention is on one end and postvention is on the other. In actuality, I feel that this model is better because suicide prevention to me and to many people that I've surrounded myself with is just a continuum. And when certain communities are able to have things in place from prevention, intervention, post-intervention, which is kind of for the people who attempt and survive those attempts, just because sometimes they get put into the postvention section, but in actuality, they have a lot of different needs than people that are bereaved. Although there are some similarities, yes, they're both extremely difficult situations, but the way that they kind of go through and navigate the system is extremely different. And so it's important that, for each community, if you're able to have these, then we believe that it can lead to that reduction in suicide that we're all looking for. Just a little bit about postvention at OSPF. So we identified a need for this in-house postvention manager. OSPF has kind of done postvention on a contract basis. kind of working outside and having people come in and do certain trainings. And that was wonderful. We did a lot of work for the last couple of years, but we really wanted to make sure that there was that in-house person that could really focus on postvention and include it into all those programs and initiatives that we have here at OSPF. Because again, postvention is extremely important, and it really is kind of the first start to prevention. Again, by connecting someone who's bereaved by suicide, connecting them to services as soon as possible is going to prevent, and it could possibly prevent that future suicide from happening. And so it's really important that postvention is included in first responders and veterans and workplace and schools, making sure that we're providing postvention when, a classmate might die by suicide, or if, a coworker or a coworker's family member dies by suicide. We want to make sure that we're supporting them from all angles. And so that's why we went ahead. And I was hired in June 2nd of 2025, so still rather new here to OSPF. But my wish and my idea with this position is to continue to connect all the postvention champions from all over the state, to go ahead and build that consistent statewide infrastructure, and making sure that all of our communities are prepared to support those suicide loss survivors. Just some of the kind of, not getting too much in the weeds, but just kind of some of the areas that I'm looking to work here at OSPF is lost team development. So we're sitting around 39 teams in Ohio, and that is counting. These are the teams, if you do not know what a lost team is, that will most of the time go to the scene of a suicide and provide that immediate kind of grief support and guidance and walk alongside those newly bereaved individuals. It's a peer-based model, meaning someone on that lost team is a suicide loss survivor themselves. And just kind of that peer-based connection is extremely important with a grief that is extremely unique, like suicide grief. We also want to continue to build upon our suicide loss survivor support groups. We've trained about 100 individuals from 2023 up until now, but we want to continue to provide that direct support and support those groups going forward. As kind of Tiffany alluded to, the technical assistance for the suicide fatality reviews, we're sitting around, like I said, that map was about 47 or about 44. I have been kind of reaching out and trying to connect with as many teams as possible. And so, I have kind of alluded to the fact that there's about 47, but we know there's more. Again, I'm still in process of reaching out. So if I haven't reached out to you yet, I am going to. I want to be able to connect with you, understand how your team works, what is working for you, what isn't working for you, find ways that OSPF can continue to support the work that you're doing. And then another thing, with my experience, so prior to here, I worked at the Franklin County Coroner's Office. I was the suicide investigations and postvention specialist. I was actually the first person to hold that title within a medical legal office. And so I have really unique experiences about on scene with forensic investigation, pairing that with psychosocial interviewing, so that we can really find some of those key factors that may have led to a decedent's death by suicide, so that we can pull that information, make sure that we're reporting it to our suicide fatality review and utilizing that information to create changes within our community, find those shortcomings and find a way to prevent future suicides from happening. And so I do a lot of work and try to do a lot of work with different coroners and medical examiners and death investigators so that we can enhance scene responses, improve that immediate bereavement support, and then overall bolster the confidence levels and certifications of death, and making sure that suicides are ruled suicides, and that if something is not a suicide, we rule it accurately. And then that is where kind of that retrospective fatality analysis can come in, and we can make sure that we can improve those efforts in local communities. At OSPF, we have a lot of postvention resources. This is just a couple of them. These are free to download on our website, and can also, we can provide some physical copies for tabling events if you are connecting with lost survivors. The one in the middle, our Ohio Suicide Loss Survivors Resource Guide. It's extremely popular. I know a lot of lost teams utilize that and provide that as a resource to the individuals that they are supporting within their community. And again, I want to add more. I want to work with different agencies, different populations, and making sure that we have resources available for them. So if you have ideas, please reach out. I would love to connect and figure out ways that we can continue to improve these resources that are available. And then just what's next, continuing to collaborate between our suicide fatality reviews and our lost teams, doing things like this, case study opportunities for retrospective fatality analysis, and our psychological autopsy investigators continue to provide resources for suicide attempt survivors. It's a group that doesn't necessarily get a lot of coverage, but we want to make sure that we're providing that here at OSPF as well. Training those new lost teams and SFRCs, And then I want to ultimately give postvention a home. I want to get out, be seen, bring awareness to what postvention is, allow people to understand that postvention is in fact prevention, continue to create those community partnerships so that we can move this mission forward. And some things that we have in the works here is a video project highlighting ways that community members connect with local survivors. And then the First Step Fund. When I was working at the coroner's office, oftentimes families would come to me and they say, hey, we just do not have the financial capability to put our family member to rest the right way and provide closure to our families. And so that's something that I want to make sure that we can assist here with OSPF. And so we want to build that fund, and we're utilizing a new vetted approach. It used to be something that was just on our website, but we want to make sure that we're going through funeral homes, coroners, local loss teams, and that they come to us with individuals that are kind of financially strapped when it comes to the services so that we can provide some type of financial service and allow them to have the closure that every individual should be able to for their family member. And I will go ahead. That is all I had. So I will stop sharing so we can move on to our guest speakers. So if they would like to come in and go ahead and take over, that would be greatly appreciated.
All right. Thank you so much, Dallas. Good afternoon, everybody. My name is Dawn Porter, and I'm a senior project coordinator here at the National Center. I am also joining with my colleague Abby Collier and Heather Dykstra. And we thank you guys so much for the opportunity to come and join your meeting. We're going to do a presentation, and Heather's going to do an amazing demonstration. So I'm going to share my screen, and we're going to just jump right in. Let's see if I can make this work. All right. Can y'all see my slides? Great. I see.
Gotcha.
All right. Fantastic. All right. So our presentation is about 10 steps to an effective review. And what we know is that successful fatality review teams implement consensus-driven and consistent structure that focuses on prevention. So this 10 steps that are going to be covered in this presentation provide a strong foundation for a successful fatality review process. But before we dive into the 10 steps, I just want to take a moment to provide some information on who we are. And so we are, again, the National Center for Fatality Review and Prevention. You will hear us refer to ourselves as the National Center. And we provide regular communication to fatality review teams and partners. We also provide technical assistance, training, and connection for fatality review teams, from how to build an effective review team to engaging death scene investigators. We also have a wealth of resources, from training modules and webinars and written products and so much more on our website that's available to the public. And we support and maintain the National Fatality Review case reporting systems, which provides jurisdictions with real-time access to their fatality review data. So that's who we are. So let's dive into the 10 steps. So we start with step 1 in being prepared. And what we know is that people crave and love consistency. In being prepared, we suggest fatality review teams to set their monthly or quarterly meetings for the entire year. This is an opportunity for members to know in advance when meetings are going to be scheduled. And we find that it's easier to cancel a meeting not needed rather than trying to schedule a meeting at the last minute and seeing if everyone is available. We also recommend having an agenda created before the meetings and sent out in advance notice. I myself was a previous fatality review state coordinator for child death review in my state. And I would create an agenda for our team members and send it out in advance. And what I found is that it was very beneficial for our teams because they were able to be more prepared to bring the reports and information needed for the deaths being reviewed, and also prepare for discussion of any other agenda items that weren't pertaining necessarily to a particular death or deaths we were reviewing. So very beneficial. We also suggest developing team agreements, and these agreements can outline the expectations of team members to include their participation information sharing, data collection needs, and prevention. When we look at step 2, it's about training and orienting members. And we recommend that existing members are retrained at least every 3 years. And we talk about training and orienting members in the review process, right? So one way to help new team members or even existing folks that are filling in for existing team members is creating some form of a resource packet, like a new team member packet or a one-pager orientation sheet for folks. In this information packet, we recommend having your mission and vision available, as well as an overview of your program, your team expectations, data collection, and prevention goals. And this can really help new team members and those that are filling in for existing team members to participate and engage in the review process. Sometimes team members will want to bring guests to the meeting. You all may have experienced this. And so we recommend teams develop some form of notification process to the team leadership when a potential guest may be joining so they can be prepared. When I think about guests that join a team, in my experience, we would have medical students that would want to join and come with our medical provider of our team member. Or we would have our law enforcement agency officer bring a fellow officer to the team who may have worked the death and had more information in the investigation. And so having some process in place with communication to your team leadership of who those guests are and why they're coming is really important. And then we recommend utilizing national state resources for team member training. Again, we have resources on our website that are free to the public. And also team members can provide their own training about their own agencies. And this is a great way to engage members. Step 3 is centered on prevention. And while the review process in itself is important, and we want to identify risk and protective factors and gaps in the systems, we encourage teams to catalyze on prevention. We have found that teams who focus on prevention are most successful. And when focusing on prevention, it can help teams stay on task and keep them from getting stuck. So if you find yourself, your team, or your teams getting stuck, one way that you can help redirect your team is just ask a simple question of, how does this contribute to prevention? And so we found that that does help redirect everyone back to what you're focusing on at hand. Another way to focus on prevention is to keep your mission and your vision of the team visible during your meetings. This could be on your agenda that you send out, or this could be visible in the meeting on a TV screen, a projector, a slide, something like that. And so this is a great way to remind the members of why they're there. And step 4 is kind of a standard process for how you discuss deaths. And we use what we call share, question, and clarify. In this process, we encourage people to share information, to share it transparently and completely, and provide an opportunity to go around the table and everyone shares. When we think about this, it's you literally calling on each individual person around the table and asking them to share the information that they bring to the table. We also recommend sharing without interruption. And we know this can be hard because we all like to talk and we want to engage and have great discussion. But sometimes information can kind of get lost if we're talking over each other. So it's really important to just allow folks to share without interrupting. My experience as a previous state coordinator is that I would literally call on each individual around the table. And when a member was sharing their information, allowed a few minutes for other team members to ask clarifying questions or any other additional questions in regards to the information being shared. So we all understood, we were all on the same page before we moved on to the next person and the next person. Sharing information is great for 3 reasons. One, it invites people to participate fully. Two, sharing without interrupting also levels some power dynamics in the room by there being a consistent order and a process, and it fosters belonging as well. And then three, it creates that predictability. Sharing information is like putting a puzzle together. And that's what we're doing here, right? We're trying to identify the factors that contributed to this person's death so we can then find ways and identify ways to prevent those future deaths from occurring. And so we want to be able to identify what those gaps are, right, when we're putting this puzzle together. And then we talk about prevention, and we encourage you to think about a standard set of questions that you can ask at the end of every review. This list doesn't have to be very long. It doesn't have to be a long list at all. Just maybe a couple of questions that focus on prevention and kind of summarizing the review meeting. And so what we find is that by sharing and asking questions and clearing any information needed, teams are able to create findings for each death. And these findings will drive that prevention recommendation piece. So step 5 is about focusing on the findings or focusing on the problem. This is where the teams stay focused on findings. When we think about findings, this allows the team to be to target very specific system gaps and highlight successes. And this here is the power in a multidisciplinary review. So we want to identify the problem. We want to identify the challenge and what went well, and then take those findings and challenges and write recommendations. We also recommend a predetermined interval to review recommendations for about every year or two. However, this can vary depending on your team, your local teams. Each team is different. And also it just depends on your community, as each community is different as well. So just to elaborate a little bit more on findings, we want to shift to findings in the review process. Creating findings, again, is about identifying what those key risk and protective factors are. And then we want to review those findings with key partners to discuss opportunities for prevention, and then write prevention recommendations for those prevention strategies. So fatality review teams are well suited to identifying systems gaps and developing those recommendation ideas. But what we also know is that writing prevention recommendations can be challenging. So by focusing on the gaps or the findings, teams can funnel those recommendations to those who may be better suited in writing them. You want to be able to identify partners who can write those recommendations or even implement those recommendations. It could be someone on your team. A couple of people could be on your team that are really great at this. This is a great skill set, and they can write those recommendations. There may be folks within your community that not only can write great recommendations, but have the infrastructure in place to implement those recommendations. So it's really important to be able to identify who those partners are and make sure that they're at the table when you start in that process of shifting from the findings to recommendations. So sometimes, again, it's just being able to identify who those folks are. And I always say it is not an easy task. As a previous state coordinator, we would review our deaths, and then we had identified community partners. We didn't have folks on our team to write those recommendations or even implement them, but we were able to identify folks within our community to bring them on board. And so we would meet with them separately and bring the recommendations to the table, and then work with them together on how to write them more specific, and then steps in implementing those recommendations. I am going to turn the next steps over to my colleague, Abby.
Very much, Dawn. Hello and good afternoon, everyone. I'm Abby Collier, and I have the joy of being the director at the National Center. And so it's great to see you and hear all about the great work you're doing in Ohio. Next slide, please. In step 6, what we want to do is really start to consider the interplay between individual risk and protective factors, with family risk and protective factors, and community risk and protective factors. And we frame that as making sure we're painting a picture. Let's understand how people live, work, and play, how they access services, how they navigate their community, because we know that all of those components of how we live our lives have a profound impact on outcomes and how people may or may not be able to access resources. As you're working to paint a complete picture, you want to make sure that your team is using appropriate and sort of human-centered language. Often in fatality review, we might not know how to talk about a risk factor or a facet of identity. So making sure that you're being clear about what terms to use can be really helpful for your team. And then use all of the resources available to your team from a data and program perspective to help get that full picture. Next slide, please. Here are some action steps your team can take to get a full picture. Is to look at if your team composition matches the composition of your community. Again, you can identify strengths and not deficits. I know Dawn already highlighted that. Looking at strengths in the context of fatality review can be a little bit challenging. It can feel like a disconnect. Obviously, we're talking about the worst possible outcome in fatality review. Someone has died. However, there are things that likely went well in that individual's life, the family's life, or the community. And so from a prevention standpoint, we often think about addressing gaps or deficits, but we can also replicate strengths. And so having your team talk about those can be a powerful way to keep the team thinking about that whole context. And then again, Dawn hit on this, but I'll reiterate the importance of focusing the conversation on systems. Every single person in this meeting, every person in a community is functioning as a part of a system or multiple systems. And so often our actions are at least influenced by how those systems function, right? Think about your own day-to-day. I was just putting in a travel request at our organization. There's a whole system for that, right? Like I have a list of steps I have to follow. And all of that impacts the way I move through it. So think about the systems that are at play and how people move through them and what the opportunities and challenges are. Next slide, please. The next step is to be really intentional and proactive in your facilitation. If we were in person, I would ask people to raise their hands and I would say, how many of you have had training on facilitation? And usually like, I don't know, 5% of people raise their hands. Most of us just get handed meetings to facilitate and sort of told good luck without a lot of formal training and structure, which that works out okay, right? Public health professionals were nimble and smart and creative. But when you add the gravity of what we're talking about in fatality review, it can make it difficult to move through a really intentional facilitation if there's not training. So be intentional about your facilitation. We encourage people to address conflict when it comes up, have a direct conversation. We know it's uncomfortable, but it's the best way to keep the team moving. And as Dawn said, I'm a huge fan of a signal word or phrase, which my favorite is, how does this contribute to prevention? It's a great way to redirect the team when we get a little off center, which happens because we're human. Next slide, please. The next step, step 8, is to seek education. And the reason we include this as a step to an effective team is really twofold. One, it is a phenomenal way to engage members of your team and your community. Ask someone to come to your meeting and present on something for 15 minutes. It could be a new trend they're seeing. It could be a new program they've launched. It could be a challenge they're facing. It could be, you know, a million different things. By engaging team members and the community in the discussion, you begin to get that fuller context, right? If we go back to step 6, you get that bigger picture. Also, we want teams to seek education because when we learn together, we have an opportunity to create a shared learning experience. And through that, we build a cohesive identity as a team. Also, in what we're doing in Fatality Review, there's always things changing and evidence evolving. And so that opportunity to learn together is really a critical way we can support each other. I'll share, I was on a site visit recently, and there was just this like 2-minute conversation about disordered eating. And one team member said, oh, well, it's all about power control, et cetera. And another team member who was a psychiatrist said, actually, there's all these other factors. It's genetics, it's all of these other things. And in that 2-minute learning together, they had an opportunity to challenge some stereotypes, build a shared experience, and shape how they approached prevention. So when we think about learning together, it can be big, training, et cetera, but it can also be just speaking up in a meeting and sharing what you know. Next slide. The work we do in Fatality Review can be really difficult. The content can be heavy. And like I said, we're dealing with the worst possible outcome. Someone has died. And as a result of that, this work is hard. I'm a mental health clinician by training. And when I came into Fatality Review, I recognized I needed a really different set of individual and team strategies to keep myself well and engaged in the work in a positive way. All of the steps that we've proposed to you in so far are evidence-based steps that help build team resiliency. They help us build an identity around a shared culture. And so as you start to think about those steps, well, a personal example is I'm not a human who loves an agenda. I am notorious for not putting them together at the last minute. But by putting an agenda together, I'm furthering a culture on whatever team I'm looking at. And so as you think through these steps, it's an opportunity to think about how some of the planning can impact your team in a positive way. I also would encourage you to have your team think about team-based strategies that support well-being. Do you try things together as a team, whether that's learning or a new process for prevention recommendations? How do you collectively problem solve? All of those team-based strategies help the team build together and sort of start to see the opportunities for collaboration. And then lastly, and we probably talk about this the most when it comes to well-being, is to really intentionally have your team members think about individual strategies for well-being. Certainly that's a component of well-being, and team-based strategies are equally, if not more important, but it is a good practice to ask your team members to think about what they need to do before they come to the meeting and what they need to do after the meeting in order to take the best care of themselves. While it's not reflected on this slide, another facet of this I would encourage you to consider is how to give team members the opportunity to pass on a specific review. Maybe they know the decedent, they have a connection in some way, but creating that opportunity for someone to say, I can't do this one, is a really positive way to build collective well-being on your team. Next slide. And I'm actually going to really skip this because my colleague Heather is going to do an amazing demonstration of the Adult National Fatality Review case reporting system. So as we transition to her, I will say I'm not a data person by background, but have learned over the last 2 decades or so to really value fatality review data and what it can tell me in a concrete way about a community. So if you're not thinking about data yet, that's okay, but I would really encourage you to think about how you're going to collect and utilize data. Next slide. This is our email address. It comes to our team if there are any resources we can help you with. And thank you for letting Donna and I share today. And I think I'm turning it directly over to Heather, but correct me, Dallas, if I'm wrong.
No, you were right. We can just go ahead and transition right into the other one. I appreciate you.
excuse me, can folks see my screen?
Yes.
Okay, great. So hi everyone, I am Heather. I am also with the National Center, and you just heard from my colleagues on how to be really most effective with your SFRs or your OFRs, teams, and meetings. We're going to pivot here a little bit because I'm going to be doing a demonstration of the Adult National Fatality Review Case Reporting System. And as Abby just said, I don't know where you're at on your journey of being an SFR or an OFR or a hybrid, but to me, it's never too soon to be thinking about data collection and data reporting. And the Adult National Fatality Review Case Reporting System, I'll call it NFR CRS or CRS because it's quite a mouthful. It's a free tool. And it's been designed to support adult fatality review teams. And really, the goals are to permit consistent reporting, to help teams identify risk and protective factors, and to generate discussion or ideas for recommendations or prevention initiatives. The National Center has long supported Child Death Review, CDR, and Fetal and Infant Mortality Review, FEMUR. And part of that support has included the development of a standardized reporting system, the Pediatric National Fatality Review Case Reporting System. And I think some of you on this call are familiar with it. The National Center is now responsible for developing and maintaining the adult NFR CRS. Like the pediatric NFR CRS, it's a web-based application, and we borrowed very heavily from the pediatric NFR CRS. And you may not know it, but the pediatric NFR CRS has been around for over 20 years. It was launched in 2005. So the National Center has a lot of experience with supporting teams as well as supporting this application. The adult NFR CRS, though, was tailored to accommodate SMRs, and you're going to see that with some of the questions that I demonstrate. But it can be used to support other adult fatality review types. Within the application, users can enter new cases. You can run pre-programmed or standardized reports. You can download data, and we even have a data query tool built in. There are no startup costs or maintenance costs to use it, but we do ask that states or jurisdictions enter into a data use agreement with our home agency, MPHI. So I'm going to start just by talking a little bit about the different permission levels and access to data. So there are a few different permission levels or roles, and you can have more than one role. So the first is what we call a case reporter, and that is when the user can enter and edit individual case information. We also have a role called data analyst, where users can download individual text files. And then we have another role called case viewer, where users can see individual case information, but not edit. So you think of that one as sort of a read-only status. And then you can be an administrator, where users can enter and delete users. So if you're seeing my screen here, I am logged in to a fictional fake state here. I'm actually a member of Team A for fake state. And I am, in terms of roles and permission levels, I am a case reporter. So enter new case is visible on my main navigation. And I'm also data analyst because data download is also visible on my main navigation. In terms of access to data, as a local team member, I only have access to my local team's cases. So local team members can never see other teams' cases or other states or other jurisdictions' cases. Once the user is successfully logged in, they're going to come to this sort of landing page. We call it our welcome page. And the main navigation here on the left is how you navigate through the different features. We're going to be spending most of our time here on entering a new case. Really, I'm hoping that gives you a feel for how the system works, as well as for some of the questions that are contained in the system. So I'm going to go ahead and click Enter New Case. And it's going to take me to what we call the case definition section of the report tool. And here, the important space is it's going to assign a case number to this record review. And it's made up of these four parts: the state territory code, team county, year of review, sequence of review. And you can see there's really not too much in this section. It's relatively short. I'm going to go ahead and click on the blue navigation buttons, which is also going to save my data, and bring up the next section, which is Section A, decedent information. So there's that case number here displayed at the top. It'll be visible on all of the sections now. You can see that the main navigation has changed. It's now enumerating all the different sections of the report that are available. And you don't have to proceed sequentially. You can hop about through the different sections at any time. In order to make data entry really as easy and as fluent as possible, we've built in some skip patterns. So I'm going to scroll down here to question 10, military status and service history. And at first blush, it sort of looks like a really short question. But if I were to indicate that this person was in active duty by clicking on that radio, it's going to unhide some additional questions. We call them follow-up questions. So now there's a follow-up question on time and service, and branch, rank, and era of service. And we even have follow-up questions to follow-up questions. So if I were to indicate that this decedent served in the 2020s, then another follow-up question asks about whether or not the decedent saw combat. Now, there's a few other tools or features I wanted to highlight. You might be able to see this little tiny red asterisk on the page here. That's indicating that it's a mandatory question. That means the user can't navigate off this page, but the good news is, and what I want to point out is that there are very few mandatory questions, and the user would get an email, or excuse me, would get a message letting them know that they can't move off this page until that question is answered. And then you might be seeing an orange triangle here. If I scroll down a little bit, a couple more orange triangles. And if I hover over that, the words SMRC priority variable is going to display. And these are variables that have been identified as really being key to understanding the circumstances of the decedent's death. They were selected with our partners, the Office of Suicide Prevention, really with two guiding criteria in mind. The first is that variable important for prevention and systems improvement initiatives? And two, is the data accessible? It really is a visual cue, so there's no action if I don't answer that question. But I think it's just they're really helpful to help prioritize efforts for both data collection and data cleaning. And we also have some tools built in to help with their monitoring. And then if folks are uncertain what a particular question means, or maybe what some of the response options, you probably can't see it, but if the user hovers over this blue circle, there's a question mark in there, they're going to bring up what we call our help text. So a little bit more information about the question itself or the response options. So it's built right into the question. You don't have to pop over and grab another resource. Before we scroll out here, I thought I would just also highlight there are several questions here in Section A about mental health in the 90 days before the death. Were they receiving mental health services? Were they on medications for mental health illness? Did they receive mental health services prior to the 90 days, as well as an ED visit, etc.? I'm going to go to the bottom here and click on Save and Continue. And it's going to bring up the next section, which is Section B, Incident Information. And it's a very straightforward section. Most of the information is coming from your death investigation reports. And it's going to include things like the date of death, the time of death, the place of incident, as well as here in question 9, you can see it's a priority variable. Did the decedent use drugs or alcohol? And if I indicate yes to that question, to that gatekeeper question, then a follow-up question comes up to indicate what type of substance. All right, due to time constraints, I'm not going to go through every section. So I'm going to hop on over here to section D, which is the manner and cause of death section. It's also largely coming from the death certificate. It's a very short section as well here. But like I said, most of the information is coming from the death certificate. For example, the immediate cause here in question 2, as well as if an injury, describe how that injury occurred here in question 4. And here, if you're indicating that the manner of death from the death certificate was a suicide, I'll make that response here in question 5. You probably didn't see it, but that action unhides another section called suicide section. Yes, I know, very creatively named here. And I'm going to hop into that because it also contains a lot of important risk and protective factor questions related to suicide. Again, this was borrowed very heavily from the pediatric NFR-CRS as a starting point. So for example, there's a history of head injury. But again, we tailored it for some adult SMRs. So if we indicate, yes, there was a history of head injury, it's asking us for how did that head injury occur? Was it from an explosion or blast? Was it potentially vehicle related if there was more than one? Did the decedent have a history of concussions? Was there a diagnosis of a TBI, including when did that last head injury occur? There's a couple other questions. You're going to see that most of these questions in the suicide section have those priority variables, indicators such as history of chronic pain. Did they have previous attempts? Did they ever communicate any suicide thoughts, actions, or intent? Was there evidence that the death was planned or premeditated? And including whether or not a suicide note was present. In here, did the decedent experience a known crisis within 2 weeks of death? If we indicate yes to that gatekeeper, it's going to bring up several of those crises because we know that if an individual has some of these crises, it's going to increase their risk for suicide. So we've listed those out. I'm going to scroll back up here to the top. I'm going to go back into section D. I showed you what happens if it was a suicide. I realized from the opening remarks that some of you are also on overdose committees. For those reviews, what I also wanted to point out that maybe on the death certificate, it is marked undetermined. But if the team thinks that the death was, that the person potentially intended to hurt themselves by checking this box here in yellow, and you may not be able to read all that, but by checking that box, it's also going to enable section F2, that suicide section, to be visible. And then the last question in this section is going to ask the team to indicate a cause of death. Most of the time, these are going to be external causes of injury for you all. I'm going to go ahead. You can select one cause of death. I'm going to go ahead and select weapon or bodily force. And then when I click save and continue, it's going to bring me to section E5, which is the weapon or bodily force section. I'm going to, in my example in my head, I'm going to say the decedent died by firearm. So I'll say yes to that gatekeeper question. And then you can see it's going to keep unhiding those pertinent questions. So in my case, it's a firearm. And by making the response firearm, it unhid a few additional questions, including E and F. Was the firearm kept loaded? And was the firearm kept locked? So just really important questions to helping us understand access to lethal means. And they were so important that we put little red asterisks next to the questions to indicate that those are mandatory questions. I'm going to hop back over here to section D, and you can see it's yelling at me because I didn't put a response here in E and F, but that's an example of it barking at me. But we'll now go back to section D. Because some of you are on OFRs, I just also wanted to give you a sneak peek of the poisoning section as well. So I'm going to change this response from weapon to poisoning. Through this action, it is clearing out the information that I just entered in that weapon, but it's now going to display the appropriate cause of death, which is poisoning. And there's not a lot of questions here too, but again, when you make your response, some follow-up questions appear. So the very first question asks what was the type of substance involved at the incident. In my example, I'm going to say antidepressant, anti-anxiety. And when I make that selection, some follow-up questions appear, such as the source. In my example, I'll say bought from dealer or stranger. It was not stored in a locked cabinet. And then how was the substance taken? And I'll say intravenously. And you can see here are the different substances. If the decedent died by carbon monoxide, you would complete the poisoning section here and mark carbon monoxide, and then you could describe the source of that carbon monoxide. And then just a few other questions that were priorities here. Did they have a prescription for a controlled substance within the previous 24 months? And question C, did the decedent have a non-fatal overdose within the previous 12 months? All right, I'm going to jump here to our life stressors, risk factors, and protective factors section. Again, if you're familiar with the pediatric NFR-CRS, you'll see that we borrowed very heavily from that. It's a relatively newer section on the pediatric side, but we've really found it's been helpful for supporting team discussion as well as team's discussion about prevention initiatives. The risk factors themselves are grouped around some rather large headings. So for example, the first is social economic. And I'm going to keep scrolling here. Medical. So for example, lack of family or social support for care. Relationships. School. Technology. Transitions. Trauma, and other. Now, what's different from the pediatric side is we've put on a yes, no, unknown for every question. So this is asking, did the decedent ever experience in their entire lifetime, in this example, a rape or sexual assault? And if you indicate yes to any of the life stressors, then two follow-up questions appear. Was that factor present in the 90 days before death? And you have the same options, yes, no, unknown. And did it contribute to the death? Yes, no, unknown. At the end of this section, we've also added a new question for adult NFR-CRS, which asks about protective factors. Did the decedent ever experience any of these following protective factors? And the time frame here is in the 90 days before death. So things like a positive social support, hope for the future, positive coping skills, etc. I'm going to skip next to our findings section. You heard Dawn and Abby talk a little bit about that as an important part of your reviews. And this is the space where you can capture that information. It's the space to note findings from the review, whether it be challenges that you could note here in question H1, or positive elements here in question H2. So maybe there was a really strong death investigation done, or maybe the decedent was really active in their spiritual or faith community. Some teams even find ending their review on this question on a more positive note is helpful. But question 3 here is the priority variable, and this is the space where teams can enter any recommendations or initiatives that were discussed, and up to 5 recommendations can be listed here. In section I, the questions change. A slightly different flavor here is going to ask about your review meeting itself, things like the date, the number, if the review is complete. But then things like which agencies and individuals were present, as well as what the data sources were available at the review. And we even have a question here in 6 that asks if there were any barriers or factors that reduced meeting effectiveness. So things like records or information was needed from a federal entity. Over time, maybe you'd want to look at this data and see if there's some themes that are popping out. We'll go to K here. This is the form completed by section. What I just wanted to point out here is there's an opportunity to indicate that data entry is complete for this case. So maybe if you're going to run reports or do some analysis, you'd only want to include those records where data entry has been marked complete. The very last section here for data entry is what we call our data quality review section. And you had heard me talk about those priority variables. And this is the place where it's going to list each of those priority variables that had the response unknown selected or it was left blank. And so they'll be enumerated here. And if I quickly eyeball this and say, oh, here, I know our team has information about the date of birth, I just click on that hyperlink that says navigate and it takes me right to that question. And I'll enter in that information. And when I go back to the data quality review section, you can see that date of birth has disappeared from my listing because it's what we consider a completed response. So really this is a helpful section, particularly I think for new teams or new users to the adult NFR-CRS, because it's a great place to sort of focus your energies in ensuring data completion. So that sort of ends the enter a new case portion of it. I'm going to pop over here to manage cases. This is where the cases are always going to appear here. So this is the case we just created. You can do some filtering if maybe you wanted to only get motor vehicle or asphyxia deaths. It would filter those cases to be visible here. What I wanted to show you here, if you're familiar with the Suicide Consolidated Risk Assessment Profile, we've also built that feature into the adult NFR-CRS. So I would come here to Actions and I'd indicate Generate Scrap. And it's going to generate a Word document that contains those scrap questions. And here it is. It may, if you are familiar with the scrap, it might look a little bit differently than that one pager you're used to seeing. We've just done some formatting changes here, but all of the questions are from the scrap have been programmed into the adult NFR-CRS. And then we've laid it out such that events that are a little bit more distal from the date of incident are put first. So for example, in the last 30 days before death, did the decedent have the following? They experienced interpersonal violence. It's marked yes here. And if I'm looking at this and maybe I'm seeing an unknown here, like job problem, there's also a little guide here that would tell me that this question actually resides in section F2, question K. So that's scrap. I'll just real quickly scroll through it. You can see all of those risk factors questions. I know you can't read it, but then we've also included the narrative. So again, if your death investigation is trying to complete that scrap report, it's just a real helpful summary to have about those risk and protective factors for that decedent. Okay, let's jump to data download. You heard me mention I'm a data analyst for my role or permission level. So that means I can download data for my team. The data is saved in these individual text files for each section, but we've also built in the capability where all of the data is basically saved into a giant Excel spreadsheet. And that's option 2 here under what we call the all variable flat file. So if I click on this hyperlink that says filtered download, again, sort of brings up some filtering options that I could do. Maybe I don't only want to create a download of records from a particular death year. I could put those parameters here. I do absolutely nothing. I click on create all variable flat file. What it's going to do is put 100% of my variables into a giant Excel spreadsheet that looks like this. And it's going to put all of my decedent records here. So in my test database, I have 11 cases here, and these are all of my variables. And if I scroll to the end, you can see I go all the way to column ATB because it's containing 100% of all of the variables. Here at the National Center, we often will take that all variable flat file and we'll import it into SAS or SPSS to do some further statistical work. But I just wanted to give you a sense of data download. We recognize that teams have a variety of data resources available to them. So we've also built in some pre-programmed reports that we call standardized reports. So if I click on that hyperlink, it brings me here. There's currently 19 reports that are available. They're mostly organized around causes of death here. But then there's also some filtering that you can do at the top by age and sex, ethnicity, race, and even you could choose to run a report maybe just on veterans, for example, as well as some time frames. The reports themselves are very basic. Most of them are just providing counts. I'm going to go ahead and I'm going to show you, since we just did the scrap for an individual decedent, I'm going to generate the standardized scrap for aggregated decedents. So I just click on that radio. I'm not going to do any filtering, and I hit generate report. It's going to put my output here in this space, but you can export the reports into other applications. I'm going to do it into a PDF so y'all can see it better, and excuse the scrolling here. So here at the top, if I did any filtering, it's going to put my filtering criteria up here. But here are those scrap questions broken out by an age cohort. So I've got 11 test cases. Again, I showed you that scrap question, did the decedent experience interpersonal violence? I have 2 records. They were both in my fake case information between the ages of 35, 44. I could dump this into Excel if I wanted to create some percentages or proportions. Another standardized report I'll show you is that findings report. I'd shown you section H where you're listing those challenges, protective factors or what went well as recommendations. Any record or case that you've entered that has something entered into those questions, H1, H2, H3, they're going to show up here in this report. And then there's a little bit of demographic information as well as the age, the manner, the cause. So it's just a real easy way for you to pull out your team's recommendations. If I dumped this into Excel, I could do some further sorting, maybe by the cause of death, and sort my information that way. But again, I just wanted to show you that it's a real easy way, real quick way to pull out your data on your findings. And then I'm just going to pop over here to Data Explorer real quickly. I like to say that we're going very slowly into the data visualization world. So this is sort of our first attempts going there here with building a tool right inside the application itself. But basically it means you can create a bar chart in a PDF or create a little mini Excel spreadsheet, but it's restricted to these 25 or so variables that are in this drop down, things like manner, cause of death, disability or chronic illness. Since we're kind of running out of time, I'm just going to generate a bar chart here so you can see what it looks like. So I changed this first option to be a bar chart. And let's say I just want to generate a PDF that contains the count of my records by death year. I could do some filtering, just like you saw on standardized reports. I'm not going to do anything, and I'm just going to say generate report. And here's what it looks like. Make it a little bit bigger for you all. If I did any filtering, it's going to put those filtering constraints there. And here you can't see this, but this is giving me a count of my cases, which is a total of 11. And then it's created a bar for each year of death with my appropriate count. So again, a really easy way for me to get information. Maybe I'm an Excel user. I could go recreate a more dynamic chart in Excel, but at least I do have the information there. In terms of the Excel output, I would just choose Excel, say again, if I want it death year, I'm not going to do any filtering. I say generate report. It's just going to, again, give me an Excel spreadsheet with those 25 or so variables. And all it does is it's sorting death year in ascending order. This could be helpful. Maybe you want to create some pivot charts off of some of these variables like sex or residence or military status, or you could use it for some quality assurance efforts to make sure your information's complete. Okay, let me just pop on over here to our help page. What I wanted to show you here is we've been building out a lot of resources. We've done some brief tutorials for each of the different features of the case reporting system. But more importantly, under here is we've got some links to some valuable resources, including the VA SAMHSA's the Promising Practices for Suicide Mortality Review Committee's toolkit. This is also a place where you can find the report form if you want to know what questions are asked in the adult NFR-CRS, a full-blown user manual, data dictionary, codebook, etc. Our report form is also on our website at ncfrp.org if you do want to get a peek for those questions. And then I'll just end by saying this training site is available for folks. We're happy to create logins for folks if you want to explore it further. And then if you have any questions, you also can reach us at smrc@ncfrp.org. And I haven't looked at any of the chat, so let me know if any questions have come up.
I know Dawn was in there taking care of a lot of them. But
Great.
Do you have any more content, or are you ready for additional questions? I can
I
open it
think
up.
I think we're going to open up for questions for both Abby, Dawn, and myself.
Yeah, that's awesome. Yeah, I will go ahead and stop the recording. And then if anyone, I know there was some conversation going on in the chat, but if anyone would like to come off mute and ask an additional question to any of our speakers, feel free to do that now.